So at the outset, I would like to thank the organizers for inviting me today and giving me this opportunity to share my ideas. Uh, Today, I am going to discuss about the dilemma of polypharmacy in primary care. This is the commonest thing that we see day in, day out in our day-to-day practice prescription full of list of medication, especially when patient doesn't has to pay, means patient coming from taking benefits from various schemes. Uh, the disclaimer is I have taken help of academic GPT, Dr. Uman Dhruv, and of course Chat GPT in preparing this presentation. Uh, so thank you, sir, for that. Now, let's not go into the definition. For according to me, the polypharmacy is prescribing too much. Either we are prescribing too much of things, or either we are prescribing too little. We are not prescribing what is exactly required for the patient. There are types of polypharmacy. First is we all people are we are they are the part of the system. It is driven by providers. We provide multiple drugs. Say for example, a symptomatology doctor, most of them are, because we do not give time, we give drugs. So for everything, for headache we give something different, for chakkar we give something, for gas we give something, without looking into the drug interaction that this been already been going on. Second is there is a dictum called age is this, start taking vitamins, start taking calcium, start taking this and that. So unwanted, not required vitamins. Then CT all, the current what we have learned in our residency days, continue all. Nobody takes any pain to do anything. CT all is the easiest word to write. And as I said, symptomatology. And another is media driven, industry driven, peer driven, quacks driven. This is effective, this will not cause side effect, this is so-pathy drug, this will not side effect. So along with the drugs that you are taking, they keep on taking multiple drugs. Now why we need to discuss this? Because we have got a fear of drug interactions, suboptimal outcomes and risk of adverse reaction. And that's we always fear in case of diabetes patients more in time. Now what are the potential risk of polypharmacy? First of all, it exacerbates the common diabetes complication. It may lead to hypoglycemia, may lead to cardiac and kidney side effects. Then some drugs may mimic or worsen the diabetic symptom, and at times it makes our clinical decision more complex and more difficult. So we may not come to a conclusion what exactly how to prioritize the drug and what to do. So this is a serious matter and something we must do something to address it. Now what we are supposed to do? We know the problem. It is there since decades together. It is not new. Now, what we are supposed to do? First is comprehensive medication review. And I think that's the primary job of we being a family physician. Patient is keep on visiting various specialty doctors, orthopedic surgeon, diabetologist, physician, this and that. And they come to with us with the number of files and everybody says, continue with the medication as advised by this doctor, you continue with my medication and the drugs keep piling up. And they come with big plastic box having lot of medications even which I think you or me cannot be able to remember correctly. Then, so review is very essential. The first thing when I see a prescription of any particular scheme, I just first check the drugs which are unwanted. So I start immediately unchecking the drugs that please stop this, and time bound prescribing. Let's be specific in what we prescribe. I have seen patients taking this rabiprazole with levosulfuride for years together when we know the indication is very time bound. Then there are patients who take medicine for chakkar. X brand is very famous. They keep on taking for years. So they ये बंद करूंगी तो मुझे problem हो जाएगा. So they have got fear of stopping it. Or we know it is very psychological. No patient needs to take this drug for lifelong. But still this happens. Then you should be using tools like Bayer's criteria. I will coming to that, and stop and start criteria, which helps us in giving good prescribing guidelines, and de-prescribing. Dare to stop the drug. In a patient who has undergone angioplasty or a bypass surgery or something, we commonly see patient is on multiple antiplatelet drug without indication, or because patient is not following up with his or her cardiologist. So they keep on drugs for lifetime, which carries a potential risk, and benefits are at particular moment and other. And we are all aware, okay, when we start prescribing, we need it for 6 months, 12 months or something. Aggressive treatment is only needed for a specific number of time. But still, they are keeping the drug because they say, अब अच्छा हो गया, डॉक्टर के पास जाने की जरूरत नहीं है, दवाई तो मैं खा रहा हूँ, प्रॉब्लम क्या है? And I have seen lot of patients, they keep on doing various reports, उनकी फाइल में पड़े रहते हैं, कोई डॉक्टर के पास नहीं आता. So that are lot of problems to be addressed. And there has to be a collaborative care. Whenever an ex super specialist is prescribing something, he or she must speak to the primary care physician that I am prescribing this, please take care of this. This may cause hypokalemia, this may cause hypoglycemia. Surgeon prescribes the levofloxacin like anything, patient ends up in hypoglycemia. So there are problems to be addressed, and then the problem starts. So there has to be a collaborative care, because we are now going into the era of super speciality, where everybody thinks that they are super and they do not need to talk to the primary care physician or the physician who is in particular looking after the patient. So connect with and collaborative team efforts is must for all. So the key takeaways are: polypharmacy is really a growing concern, with the number of hospitals, number of specialists becoming more and more. As I said, number of super specialists becoming more and more. This is really a problem, and especially more in diabetic patients. So careful medication management. And as I said, regular review. This is required. This is for 10 days. This is for 15 days. Today only I've seen a prescription whose patients were liver enzyme high. Patient was taking 15 drugs, 3 antibiotics for diarrhea, and primary concern was something else. And this was prescribed by a leading novel, well-known physician from our area. So we can't blame quacks for everything all the time. So collaboration is required, regular review is required, and we must dare to de-prescribe a drug whenever it is not required. Now, couple of slides about the Bayer's criteria. This is basically formed by American Geriatric Society. It is now available as an app, but it is a subscription-based app. Now, what they do is they gives a checklist of medications to be avoided. Say, for example, in senior citizen, they say you don't use benzodiazepines. So it causes more sedation and there are chances of fall and everything. There are some medications marked as medication with risk, which can lead to serious side effects and injuries. Drug to drug disease interaction. I always keep drug interaction checker open in my desktop all the time, because there are a lot of drugs which I don't know. There are a lot of no molecules all the time which are coming. So when I'm prescribing something new, I always check the drug interaction checker, that whether this is compatible with the drugs already going on or not, and dosing recommendation. So this BS criteria is quite a comprehensive thing, and they keep on revising it all the time period, or on various occasions. Then the stop and start criteria. Stop which is not required. As I already said, there are a couple of chakkar medicine, acidity medications, this and that, some medication for vitamins, some this. They keep on going for lifetime. Nobody dared to stop them. There are a lot of aged patients who keep on taking NSAID drugs for various kind of pain. They feel we have been told कि जब पेन होता है तब ले लो. अब जब की definition मुझे रोज पेन होता है तो मैं रोज लूंगा. Simple as that. So we have to be precise in what you are prescribing. And especially, we see the rampant use of combination, rabeprazole, domperidone, rampantly used all the time, every time, with even a routine antibiotic, there is a co-prescription coming up. So that stop criteria must be done. At the same time, we must start the drugs which are essential. We are shying away in starting statins, which is the very important drug for diabetes patient, we know. But if you see a lot of prescription moving around, you will not find statin in indicated class of patients. Aspirin, there are some patients in where PPI are really required for shorter period of time, they don't use it. So stop and start both is required to have the balanced prescription. Thank you very much.